Hi, everybody. Thank you for joining today's CREP webinar on. We're going to be discussing today on advocacy of exercise professionals. We're going to be highlighting some major accomplishments that we're fighting for health fitness professionals in 2024, kind of a reflection of that and kind of how we're preparing for 2025. I have the pleasure to have our panelists, Graham Melstrand, Lori Witzel, and Mike Nargunsky, to join me today. Maybe we can start with kind of quick intros, and we'll start with Graham first.
Sure. I'm Graham Melstrand. I'm the founder and CEO of Active Sport Advisory, and I'm a past president of CREP, which operates the U.S. Registry of Exercise Professionals and the Physical Activity Alliance.
Wonderful. Lori?
Thanks, Francis. Great to be here today. I'm Lori Witzel. I'm National Vice President of Policy Research for the American Heart Association, and I help lead the Physical Activity Alliance as Senior Advisor. Thanks for having me today.
Great. Thank you. Mike?
Hey, I'm Mike Gazinski. I'm the Vice President of Government Affairs for the Health and Fitness Association, and I'm also the Policy Chair at the Physical Activity Alliance.
Cool. So let's start with a reflection of 2024, and would love for you all to kind of discuss what the most significant advocacy accomplishments happened in 2025 for exercise professionals. And Lori, Mike, and Graham, who would like to start with that?
Lori, why don't you kick us off, talk about It's Time to Move and some fun stuff that we've been doing at PAA.
That'd be great. Thanks, Mike. So our signature initiative right now with the Physical Activity Alliance, or one of our key initiatives, is our It's Time to Move initiative. And that's really standing on the shoulders of all the great work that's been done in the past. And it's continuing to happen with exercise as medicine and other great work across the United States. We're working on the national policy and systems changes needed to integrate physical activity into healthcare delivery. And so, that'll just help continue to propel all the programs and exercise interventions that are happening on the ground. So to Mike's point, we had some great accomplishments in 2024. I'll quickly summarize them. What we're trying to do in that initiative is identify the barriers to making this a standard of care and address them one by one. So we started out, one thing we heard from clinician champions is, gosh, I wanted to institute this in my healthcare system, but it took me 2 years to get the measures inside our EHR. And so we thought, if we can do that nationally, develop standardized measures and put them into the language that healthcare systems use to exchange information, that might help reduce one roadblock. And so we worked in an organization called Health Level 7 International to build out the first ever implementation guide for integrating physical activity measures, and that's for assessment, prescription, and referral. So the whole standard of care into clinical care. So this implementation guide is now out in the public domain, and we're working on health system uptake. And that's not easy. Just because you have the measures doesn't mean the health systems are automatically going to integrate them. So we were able to establish a collaborative in North Carolina, working with all the health systems and Epic as the EHR vendor, and community-based organizations that are part of the alliance, and ACSM is, of course, at the table, and CREP. But, how do we make this really happen? How do we get it implemented? And if we can demonstrate that in North Carolina with a good, solid pilot, we hope to then be able to scale nationally. And then at the end of 2024, we convened a benefit design roundtable. So we really need to address coverage and reimbursement for exercise interventions and supervised exercise therapy. We've worked with Avalier to help us think it through strategically, but having this roundtable was really helpful. It gave us some next steps that we might be able to pursue that we actually are going to pursue this year. And it was great to have some of the federal agencies involved as just observers for the day.
Mike, what are your thoughts from the HFA?
Yeah, from the HFA perspective and some of the work that we've done at PAA, we really set to establish the foundation necessary for us to be working with the incoming administration, making sure that we're keeping physical activity front of mind, and that we are making sure that the work we're doing on the It's Time to Move campaign and everything that we're doing across the board to make physical activity considered a pure vital sign that's not only looked at and taken care of in the medical community, but also as Lori mentioned, referred out and prescribed ultimately for reimbursement for individuals to use physical activity for all the mental and physical health benefits in their preventive health life. So it's a great opportunity. We spent a lot of time preparing for, regardless of who won the presidency, who's in charge in the Senate or the House. And happy to say that all of that work has led and prepared us coming into 2025 to really look and aim high to achieve some great things.
Cool. And Lori mentioned how the EHRs, electronic health records, and referral going from the physicians to the appropriate level of program. I guess I want to ask that to Graham a little bit. What does that mean for the end user of the exercise professional? We're thinking about the referrals. Why is the EHR part important?
Well, sure. And I think that one of the most important things on this is if you have physicians assessing the level of physical activity for their patients, either no physical activity, inadequate, or meeting and exceeding the physical activity guidelines for Americans, it facilitates that conversation to offer them an exercise prescription and then refer to the appropriately qualified exercise or other professional in their community for the programs and interventions that are going to best meet their needs. And I think building on what Lori shared, there were a couple of really interesting things that happened this year as the PAA started to explore some of those coverage determinations. I think there was an honesty in the conversation that perhaps we haven't heard before, in that a lot of our focus has traditionally been on prevention. And they were very frank in saying, well, sure, but that's difficult for us to measure and apportion the cost and realize the benefits from. Where we really need some assistance now are from or for individuals that have diagnosed health conditions, diabetes, hypertension, people that are at risk for falls, and saying that what can you do to provide programs that would be scalable and accessible on that, and then who are the most appropriate deliverers of that. And so one of the things that we've been able to do cooperatively is work on a national exercise referral framework that puts the primary care practitioner in the driver's seat in terms of saying, okay, based on the level of supervision that I will require for this patient, what is the right combination of credentials, academic preparation, and that respects the highest and best use of the credential, but still provides the patient safety and quality that you're looking for. So I think those are some of the things that are maybe really top of mind. And then maybe stepping out of the healthcare space a little bit, I think that the work that was done with the Association recommendations for strength coaching, we're seeing traction in the college and universities for that. It's an athlete safety issue. And CREB's Athlete Alive 2025 has some terrific champions that are supporting the efforts there. University of Michigan, University of Arizona, Cal Berkeley are all champions for that, making sure that the athletes have access to those qualified individuals, and that there's coordination between the athletic training, sports coaches, and the medical oversight that they have there.
And then, Lori, I wanted to dive in a little bit more to ask you the question on, when we're talking about benefits design and the work that the PAA has done, what does that mean? Are we talking about people, or are we talking about programs? And I'm talking about it from is it a multidisciplinary program, or is it individual people? From the PAA's perspective, what does that mean, I guess, for when you're thinking about as an exercise professional? It's like, gosh, I'm qualified through some sort of combination of education, certification, experience to work in different types of programs. What does that mean for those individuals and kind of what PAA is doing?
Sure. So I think the qualified exercise professionals are really interested in reimbursement. So we talk about reimbursement and coverage. Reimbursement is payment for service, payment for your services. And so as we talk about that, I think, and we've had just in the last week, some really interesting conversations with both CMS and CMMI, which is the Innovation Center at CMS. So I think there are current reimbursement pathways, and then, maybe we can be a little forward looking and future looking. Under current reimbursement pathways, since qualified exercise professionals are not licensed healthcare professionals, they aren't able to bill directly for their services, but they fit really nicely in a team-based approach to healthcare. And so And that team-based approach can be in the primary care office or, with a primary care physician, in cardiac rehabilitation, in medical fitness centers, in programs that are evidence-based programs that are offered in the community. They can be those that deliver those programs. But how we pay for their services is probably, there's going to be somebody that has to bill for them. It could be the physical therapist, it could be the physician's office. So we can pursue those opportunities now, but then we can imagine a future where under alternative payment models, there might be the opportunity to refer to exercise professionals. We really want to work on the ability for patients to be able to go into evidence-based programs or exercise interventions that are offered in the community. How do we pay for those? Right now, you can't do physician oversight on those. So can we do the oversight through the PT office? Other ways? Is there a way that CMS and the private payers would pay for those programs directly? So that's what we want to explore with alternative payment models or new ways of thinking about reimbursing for services. But right now, we're probably going to have to work disease by disease, condition by condition, work under the current reimbursement pathways that require physician oversight or supervision or PT supervision, and go that way. And then we'll also continue to look for innovative pathways as well. Does that help?
Well, that's super helpful. And I think it's very helpful for our audience to really understand kind of where we are. And I think there's just like understanding their role in kind of where advocacy is going. And I guess the question for the three of you is kind of thinking about in 2024, has the role of an exercise professional evolved in kind of the where they position themselves in healthcare and public health? What does that mean? Has it changed over time? Think about prevention versus kind of like reducing kind of or improving health outcomes. Kind of what your thoughts are there? I'll open up
Well,
to
that's the other thing too, is that we'd like to see it not just for treatment of conditions, but also for prevention, right? That's the holy grail. But that requires some cost effectiveness analysis there, right? The ability to show return on investment of paying for that service. It's the first thing payers are asking for and need to know. First thing that health systems want to know. So this is where kind of doing additional research, working, with the research community to answer some of these key questions will be an ongoing important bit of work. Yeah.
Absolutely. I'd love to kind of explore that maybe a little later on in our discussion. Graham and Mike, any other thoughts?
Yeah, I'll just jump in. We actually, touching on the research a little bit, the Health and Fitness Association just released some great price elasticity data that shows what these types of government intervention and allowing, increased access and utilization of the industry and utilization of physical activity from the treatment perspective, but then shifting it to a preventive-based model, what it would mean in terms of economic generation, healthcare savings. And so we have some great data that shows that, if we move to this direction, implementing items that you may have heard me talk about before, like the FIT Act, and making sure that we can generate that referrals out and having people utilizing physical activity preventive health could prevent upwards of 500,000 chronic disease cases a year. And there's deaths from that reduced down by nearly 5,000 a year. And then also thinking about the healthcare savings, looking at nearly a $12.2 billion savings to the healthcare industry each year from leaning on that preventive model. As Lori mentioned, though, we do need the data and the real research, the test cases, to see how these interventions actually help in the real life environment, right? With proven test cases and pilot projects. So that's really where I think we have the opportunity to invest some time and energy in on the research side moving forward, to really be able to make the case that this is the way that not only the federal government should be going, but the overall healthcare community and continuum.
I think one of the things that's going to be an opportunity rather than a problem to solve is, given that the majority of Americans still receive their health care through their employers, and that there's transition from provider to provider for those insured, is being able to make the business case at the actuary level for those private payers that are going to invest in some individuals that will move on, and then have some that come along that hopefully will have improved health status as well. Francis, going back to your original question, I think one of the things that I would say is maybe not an evolution of the role of the exercise profession, but I would describe it as really an evolution in the relationship that we have with government, that we have with payers, that we have with healthcare, where our space through organizations like CREP and HFA and the PAA in particular, really finally have that seat at the table where we're having those thoughtful conversations and talking about the progress we've made and commitment towards professionalizing the space and the role that we can play as that expert resource for programs, interventions, and motivation at the community level, whether the goals are health related, fitness related, or sports performance related.
So, and I guess it's like I want to do one more follow-up before we move on to kind of how we're planning for 2025. And I guess is there a difference in when we're thinking about the payers? Is there a difference between how you approach it with ACOs or accountable care organizations, socialized medicine like Medicare or Veterans Administration, and then private payers? Is there a difference in how you approach that, or is it about the same?
Yeah, it's a little different, I would say. We're shifting toward a value-based healthcare system in the United States. We're not there yet. There's been movement in that direction in significant ways. But I think our work fits really nicely in the accountable care organization model, that value-based team approach, where clinicians are incentivized to keep people out of the hospital or reduce healthcare utilization. I think that's where we fit best. So we want to be part of that continued evolution.
Right. Thinking about 2025 now, and so I think that's everyone's top of mind for a lot of our organizations. When we're thinking about that, what do you think the top priorities or advocacy priorities are for in 2025? And I'll leave it to the three of you how you want to answer that.
Yeah, I'll jump in. I think, we, to put it bluntly, we have a great opportunity before us. The new administration has expressed an interest, and we've seen with the confirmation of Robert F. Kennedy Jr., even in talking throughout his confirmation hearing about the need for fitness, the need for physical activity, and the importance in that in the American healthcare and the health community. Has really opened up an opportunity for us to speak to friendly voices and finally push some big thinking initiatives that we've been focused on for so long. And thankfully, through the work of the Physical Activity Alliance, the groundwork is already set, and we have almost our key priorities list ready to go to talk with the administration, talk with members of Congress about how we can actually achieve the goals that the president and Robert F. Kennedy have laid out throughout their campaign and coming into the new administration about reducing chronic disease, focusing on the American healthcare system, but also focusing on ways that they can make the average American a healthier, more preventive of chronic disease individual and population. And so as we look to the near term here, where we are steadfast at HFA and making sure that we are taking advantage of this opportunity through the work that Congress is currently doing to finally get the FIT Act, which I've spoke on before, which would allow HSA and FSA eligibility for physical activity expenses like gym memberships and youth sports expenses for children to get physically active in their communities. We're looking at ways to get that involved in a major package that is moving through Congress right now, and working with our folks and our friends at the Ways and Means Committee in the House of Representatives to make sure it is. And so, the legwork has been done, and thankfully we have a receptive audience for at least the first time since I've been working in the industry, but really making sure that, we're connecting those dots and helping the new administration focus on physical activity in a healthy way. In addition to that, we're looking at sky's the limit. There's opportunities around just ways that we can work within HHS and CDC and the administration itself to really elevate physical activity and the positive mental and physical health benefits that it brings to the community. to the forefront in all of these discussions. So we're very excited, and we're looking at every possible opportunity to make sure physical activity has its seat at the table.
I think it'll be important to really to continue those, as Mike said, those, building those relationships. There is a lot of emphasis right now around prevention, actually, in this administration, and so I think that's a really incredible opportunity to insert our It's Time to Move work and other work. We also want to get the physical activity guidelines in statute so that they're mandated by Congress, like the dietary guidelines. That kind of protects them in terms of making sure that they're going to continue from administration to administration. And then I think have already been talking to CMS, and we're going to be continuing to talk with the Assistant Secretary for Technology Policy. So this whole work on interoperability and exchange of, prescribing exercise interventions, making that seamless in healthcare is going to involve technology. And so we're going to pretty much, there are a number of agencies in HHS that we're working closely with and that are excited about our work right now.
Great. Any other thoughts on that, Graham?
Well, yeah, I think just making sure that the exercise professional and those organizations that employ them have that seat at the table and they're part of the solution. And making sure also, Lori, you mentioned people and technology. It's not a people or technology, it's a combination of both. And the richness of the data and the ability to interpret that data and attach it to the research, I think is a critical piece. Talked a little bit earlier about the work that happened with the NCAA on the athlete safety. At the high school level, you have 10 times the number of athlete deaths that you do each year at the collegiate level associated with out of competition conditioning related activities, and really working with the school districts in the states to consider the inclusion of qualified strength coaches as the designer and deliverer of those activities associated with youth sport. There's been a lot of progress on the athletic training side, but right now they're kind of standing all alone to clean up the mess of those individuals that are designing or delivering programs that are inappropriate for those individuals. So that's those are the things that I think about that are maybe additive to Mike and Lori's comments on that. I agree with them on both sets.
Great, thank you. So I think maybe I can ask this question to Lori. It's just like, what advocacy efforts are underway to increase the recognition of exercise professionals in healthcare? And I wonder if there's an opportunity for you kind of describe your work in North Carolina with the Physical Activity Alliance, with that collaborative you all are working on. Could you describe kind of the process of what you're doing there and kind of why it's important for the end user?
Sure. We do have kind of a progression, a sequence, I should say, of what we need to try to accomplish. And that would go something like integration of our measures into EPIC, into the EHR, and then identifying maybe a priority condition for applying physical activity assessment, prescription, and referral. And so that's then it's integrating into the health system and health system workflow. And then we've got to work on connecting to community-based organizations or medical fitness centers or cardiac rehab programs. But ideally, we're really trying to solve for the community-based organization, what's delivered in the community-based organization. So how do we get that referral out? How do we get it paid for? And then what's the feedback loop? Our implementation guide allows for the feedback to the clinician on what happened. So there is that progression, and then there's also educating the clinicians, and it's also aligning financial incentives. So we need to have quality and performance measures that incentivize clinicians to actually have this conversation. I know Liz Joy always relates when they integrated physical activity vital sign at Intermountain Health. They had to, have a quality and performance measure that said, says to clinicians, you do this or you're not going to get paid, or you're going to get paid less. And at first, it took a little bit of time, but then because of that incentive being in place, it became a standard of care. And then you can pretty much pull that incentive out and then it continues. Once you get it up and running, then it's pretty sustainable. But so there are multiple angles we have to address here. It's a huge effort, and integration into healthcare delivery is not easy these days. Clinicians have so much on their plate. Health systems have so many other priorities. We are one of many that are coming, to ask for their time and their resources. So if we can demonstrate this in a pilot way in North Carolina, I really hope we can help scale it nationally.
Good thoughts. Okay, so the next question I have for you all is, when we're thinking about reimbursement, I kind of think about the schoolhouse rock of how does a bill in Capitol Hill. I don't think folks really understand how programs get reimbursed. So I wanted to explore that. I think one is, how does a reimbursement work? And then talking about the research and kind of policy-driven kind of research that potentially we would need in the future. So I want to ask the questions, just like, if we're looking from the exercise profession's perspective and securing reimbursement for their services, how are you all kind of thinking about, how do you address that? Like, what are the things that are needed for reimbursement? It's a little bit of a loaded question. It's a hard question. So
it's a complicated question. Yeah. Because there are any number of ways to do it, to approach it.
Yeah, and maybe a good place to start is right now, from the HSA and FSA perspective, we know that if a certified medical professional was to submit a letter of medical necessity, the onus is always on the consumer. So the consumer would then come to the exercise professional for services, would do the payment in a normal fashion, and then submit the receipt for reimbursement. I think, if Lori or Graham want to touch on some of the items of, if we look at the big, hairy, audacious goal and what at the end of the day is possible, that would likely change. It would likely be a direct processing of either an HSA card or an FSA card, but there could be a direct transaction reimbursement. So there's just a lot to think about in that regard.
Yeah, and the HSA and FSA is kind of a good place to start, because that guidance comes from the IRS, and there's some pretty tight sets of fences that are built around it. It has to be for a diagnosed medical condition. It has to be something that's new in terms of services that are provided. And then, as you pointed out, the consumer is the one that is going to make the payment and then submit for reimbursement in the underwriting at the organization that's providing their program will determine whether or not it's covered. So there's some risk to the consumer and the reputation of the professional and in the referring physician is well on that. But it's a great place to start, because it lets everybody roll up their sleeves and get a little practice. But it also is what, Lori, it's a little over 20% of individuals have access to HSA and FSA accounts. So it's not a very inclusive set of policies when you consider the need. I think the challenges, and Lori, I know you'll be able to provide a lot more detail on this, is from a structural standpoint, there's no clear pathway for referral for programs delivered by exercise professionals today in community-based settings. Lori touched on that a little bit earlier, and that billing has to be under that primary care practitioner's set of services. There's also inadequate CPT billing codes for physical activity in general. There's some that you can kind of bend and twist to meet your needs. But I think the area where there's a real gap is there's a lack of evidence-based programs that make it easier for referring professionals to say, you need to do this program because you're at risk for diabetes, and that it's a comprehensive, time-bound, one-to-many program that also allows for one incident of billing and payment for the insurance provider. And of course, Lori talked about the priorities and the competing priorities. There's a wariness on the part of payers to just open up a whole brand new category when they're unsure about what the impact is going to be in terms of their attenuation of risk and cost.
Yeah, so to start with HSA and FSA dollars, those aren't really, so as we talk about like reimbursement for services, those aren't really a reimbursement pathway. They are the ability to use pre-tax dollars under a benefit offered by your employer to cover an exercise intervention, which is great. And it's a, it's one really important way of increasing access to these services. But if we're going to get into true reimbursement pathways, then we have to look at current fee-for-service reimbursement pathways. What we've been told by CMS is the opportunity there is to do it condition by condition, i.e. treating cancer, osteoarthritis, fall risk prevention, and model it after the national coverage determination we did for peripheral artery disease. So essentially you're getting people into a cardiac rehabilitation infrastructure. There's an exercise physiologist delivering the program, usually with nurse and physician supervision. The billing happens through the program with physicians. So that's one way of doing it. We also have the diabetes prevention program as a model too. So that was the first prevention program delivered by a community-based organization. We were so excited, it opened up the door to delivering prevention-based programming in communities. But the regulatory hurdles that were put up in terms of implementing that were tough. And so it hasn't, so there's been headway in getting that implemented, but there's still so much more opportunity to cover these kinds of evidence-based programs. And then, you think about medical fitness centers. So it's a wonderful opportunity to do the direct referral and feedback, but we have to get payment into the medical fitness centers, right? Their services aren't paid for. And how do we pay for it? It could be employers integrating into their benefit design. It could be working with CMS to get Medicaid and Medicare coverage, and states to get Medicaid and Medicare coverage. And then also working with CMS on innovative alternative payment models to think about what this could look like in the future. So they're all kinds of ways, and great initiatives like Greg Welk is doing out at Iowa and others are doing. They're finding these different pathways. I also think there's a role for community care hubs, health information exchanges to serve as intermediaries to make this easy to get for patients to go from clinic to community and handle the billing and so forth. So any number of ways we can think about it, lots of different approaches we're taking to try to get at this ability to cover exercise intervention, but it's a long, complicated road.
And Lori, there seems to be
Sorry.
maybe an additional lane that's opening up when you look at, say, the obesity action coalition, where they're working on comprehensive coverage for obesity treatment that would include intensive behavioral therapy and physical activity programming, which would be that team approach to care. At this point, when you look at the demographics of our population, that's a significant group of people.
Yeah, we do have to get physical activity purposely covered and reimbursed in that, and it's a great opportunity.
So I wanted to kind of ask this to Mike and Lori, kind of what do we need as an industry for us to show the benefit in exercise and physical activity? I think there's no question that exercise and physical activity is efficacious. I think there's no question about exercise can prevent or mediate or at least ameliorate conditions of chronic disease. I think that shows that. But seems like there's things that are missing, like the economic benefit to the payer. What are your thoughts on that in terms of research? What else do we need to have in order for us to make the case to the payer? At the end of the day, they're going to be if they are going to provide or foot the bill, what do they need? Does that need to be a part of research moving forward?
Yeah, I think so. As I mentioned earlier, when we did our price elasticity study, it actually focused on what it would look like if government intervened to reduce the cost of physical activity and thus increasing access. And that showed really great positive results. I feel that the more we can show the payer community that investing in these programs on the front end through prevention are saving on the back end through medical intervention and the need for them to pay out for chronic disease challenges and everything that comes with that, it would be vital to shifting the narrative and shifting the understanding within the payer community about the benefit of moving to this direction.
Yeah, I think it's so you can do the economic modeling work that HFA did, and kind of forecast what the savings will be, but then which is really important. But and as we talk though to health systems and payers, we also have to be able to have run pilot programs that actually show this implementation and return on investment. So the bottom line, I think, Francis, is we have to continue to bring health economists into our work, and continue to do both the modeling and the evaluation of on the ground implementation and show ROI. And it's not just value on investment. I think we're going to have to show ROI, return on investment.
I think that goes back to that. I think the cost, quality, and access. And I think what we've heard on the triple aim. Maybe Graham, can you explain what the triple aim is? Because I know you've mentioned that a number of times in presentations that we've done in the past. I think when you talk about cost, quality, and access, can you explain what that means and kind of like, and especially in the terms of scale?
Sure. And now there's a fourth element that they like to talk about on that as well. But when you're talking in the traditional way about the triple aim, you're trying to balance cost, quality, and access. Because if its quality is super good, but it's so expensive that a tiny portion of the population benefits from it, that's not helpful. So when you're looking at these type of interventions that Lori is describing and that Mike is describing as could be delivered in facilities and things like the diabetes prevention program, those things that are they fit the SMART goal model, right? So they're time bound. They have a specific time that they're running. They're structured, a referring professional, a delivering professional, and the participant in the program can all see and understand what's going to be expected of them and what's going to be delivered. And it's cost effective, and it's a single price for the whole thing. A bespoke offering in the form of personal training, or like the way most physical therapy is delivered in the acute phase, is simply too expensive. You're not going to be able to provide those services in a way that's going to be palatable or cost effective for any payer. And quite frankly, we probably collectively don't have the number of practitioners, even if you include physical therapists, occupational therapists, athletic trainers, to meet that need. So if you can build a program that is approachable from a cost, it delivers a high quality outcome, and it's accessible in communities, that's really the target that we're looking for. That fourth quality, and it's kind of a post-pandemic one, is we're trying to reduce the burden and the strain on the referring professionals and the other medical providers that are suffering from burnout associated with all the demands that are placed on them, because that impacts quality of care for patients as well.
Okay, great. Thank you so much for that. Kind of pivoting a little bit about opportunities and threats. I think when we're thinking about the new administration that's coming in, how are we all preparing and balancing between opportunities and challenges? As new administration comes in, and I know, Mike, you were talking about RFK coming in and some new opportunities. How are we as an industry, depending on whether it's the owner-operator, PAA, or kind of CREP side, how are we looking at it, and how are we positioning ourselves?
Well, first and foremost, I always like to look at everything from the opportunity side first, right? And as I mentioned earlier, we have great opportunities to really advance some things that the physical activity community has been pushing for some time, because we know that it will produce results. So as I mentioned, we're working on Capitol Hill at this time there's a big reconciliation package, the budget, and the tax package that's going to be moving through the House and Senate. It's the prime opportunity to get some of our key priorities like the FIT Act finally put into law. But then, what we're doing is watching what is going on at the agencies, making sure that we are sharing ways that they could engage the administration and the agencies in a better, more streamlined approach that could possibly really help fulfill that MAHA, Make America Healthy Again agenda that the president and RFK have spoke to. I will say, as we look at all of the work that we're doing, that, as Lori mentioned with the It's Time to Move campaign, all of this, even if we are successful, will produce future challenges for the industry that we're preparing for now, right? So, as we look towards the ultimate end zone of having, physical activity assessed, referred, prescribed, and ultimately reimbursed, what does that come with? What challenges does that pose the exercise professional, that the new trainings that they will need to undergo to or make sure that they are positioned to be able to work within that network. So all of that thought process needs to be happening now, so that we can prepare the industry, prepare the professionals, and ultimately prepare the nation for if we are successful. Lori, Graham, I'm sure you guys can touch on some more specifics than I did.
Yeah, I mean, I think there's, we are in an unprecedented time with a new administration in Congress and navigating. We're doing it with as much situational awareness as we can, as Mike said, looking for opportunities, continuing to talk to our colleagues and, those that we collaborate with in the agencies, and, hoping to make all of our work sustainable over the long term, sustained over the long term. I also think, we're going to have to be willing as we do this work to collect data. As I wear my American Heart Association hat, a lot of what I'm thinking about these days is how can we be doing better policy implementation and outcome evaluation. So we work so hard to pass policies, but then do we really know how they were implemented, and were they implemented in the best way? Did we increase disparity or reduce disparity? How much did it cost? Was it really feasible? So we're starting to think about that and dip our toe in the water and doing that kind of evaluation. I think as a community, we also have to be purposeful in doing that. If we're going to start referring people into community-based organizations, we've got to be able to track their progress and see how they do, and did this work, and be able to provide that feedback to inform better policy development, but also inform just effective programs. So that's what I'm thinking about right now.
And Mike, you touched on a concept that I think is really important, and that's kind of the idea of a coalition of the willing, right? If a lane of opportunity opens up and there's something that a large group of organizations that share a similar goal or desired outcome in that's the opportunity for them to work cooperatively to make those things happen. And as you pointed out, with these opportunities that we've long aspired to and things, there's work that needs to be done as well. If you're receiving referrals, that's going to extend some requirements around HIPAA and GINA compliance to facilities around that health data. There's going to have to be reporting of health data. We're going to have to make sure that the workforce, as you mentioned, is adequately qualified, not just education and credentialing, but ongoing education around the provision of services to individuals that perhaps have that disease-specific condition that they've been referred to a program for, and for facilities that have traditionally been focused on a membership-based delivery. You're going to have to look at alternate options like they're looking at, quite frankly, now in senior living, where you can be a member or a resident, but you can also be a member of the community, where you can access those health-related programs at perhaps a price differential, but you still have access to them. You're not setting up an additional barrier that stands between somebody and access to a program that they need for health.
Thank you. So I think one more question before we kind of start going. There's a number of questions, great questions are coming in through the Q&A side. So I want to make sure we have enough time to answer those. But I have two more questions for you all. And I think there's some wins that we saw last year. And I think maybe Lori, you can describe kind of some of our wins last year. But ultimately, one of the questions that I have for you is that, do you think organizations, and there's a lot of folks that are very interested in exercise and reimbursement and kind of that entire kind of pathway. Do you think that, like with CREP, the Physical Activity Alliance, HFA, is there an opportunity for all of these to start collaborating in advocating for the exercise professionals and ensuring that there's enough access to these programs? And I think we saw that last year was a lot more collaboration that was happening. Do you think that's something that we see going into 2025? and beyond, this deeper and deeper collaboration between not only as individual organizations, but associations? Kind of what your thoughts are there.
That's just first and foremost is going to be it's going to be the key to our success, Francis. I mean, that was the whole reason we brought the Physical Activity Alliance together, was to speak with one voice. I think if you bring consensus-based solutions to policymakers, they are incredibly appreciative of that. And the great thing is we have diverse partners in the alliance and across our community that are very interested in this work. And from industry to nonprofits to professional organizations to researchers, we want to bring everybody together to create these evidence-based public policy solutions. And if we have that consensus and can take that to Congress or take that to the agencies or the administration, I think that makes us really powerful. So to me, that's the key to our success.
Critical mass and resources matter.
Mm.
Those are the two things that create movement.
Awesome. I want to ask one final question before we go to the Q&A section, so we have enough time to answer everyone's questions. I guess, what is one action step that you all would recommend to exercise professionals if they're interested in advocacy and they know things are coming, or what can I do as the professional? How do I get involved, or how do I keep abreast to things that are coming up?
Yeah, I'm happy to start. I would say the simplest answer is stay engaged. If you are heading to the HFA show in Las Vegas at the end of next week, early the following week, come see me, come talk to me about how the exercise professional can get engaged. We have very easy ways from the grassroots level, and I think your voice matters. And if the entire industry from the top down is all focusing on the same issues and work that we're doing, it only elevates that voice. So we, from time to time at HFA, will send out what we call action alerts to not only our members, but the entire industry and community, calling on you to take action with a simple click and contacting your legislator and letting them know that you support the work that we're doing, or you're adding your voice to that list. And when you add your voice to that list, it speaks not as an exercise professional only, but as a constituent of these elected officials and policymakers, and an American that is interested in the policy that's being worked on. So that would be my calling card, my call to action.
Lori.
So I think there are a couple of things. What Mike said is great. Get involved with any organization that you are a professional member of, and actually be part of their grassroots network. And then you can join, with the Alliance. We've got some expert advisory groups working in different areas of our policy. If you're interested in joining those, definitely reach out to me. But I also want to say that, we're trying to build a movement here, and we're all doing it collectively and collaboratively. And don't underestimate the impact you're having in your own community or in your own university or in your own organization. Go back to your organization and advocate for organizational level policy, whether it's worksite health promotion, opportunities to be physically active in a healthy way at work, physical education in your children's schools, community-based sports programs. Be an advocate in your local community too, because every bit of work like that contributes to the overall movement, and you can be so impactful. And then, Francis, you and I have talked, but I think we need to build out a research consortium. It's a two-way communication with the research community. The research community needs to know that what they're doing in terms of building the evidence is policy relevant and answering the key questions of the moment. And then we can convey what we're hearing from policymakers, regulatory agencies, what we still need to learn or what we still have to answer. And so we can build this kind of evergreen policy research agenda that helps everybody. And I'd really like to see if we can pursue that and get that done.
Sounds great. Graham?
And again, it's a build on Mike and Lori. One of the easiest things that you can do is sign up for the newsletters for the three organizations that are represented here on the webinar, so that you're receiving that information on a regular basis. And as Mike and Lori both indicated, you have to be an advocate for yourself and for the sector and the profession, and that starts with yourself. Prioritize professionalism in the way that you handle yourself, that you appear in the community, the credentials that you hold, and don't forget that all politics are local. Just because the pandemic's passed doesn't mean that we don't want to have relationships and interaction with the public health departments and city government and county and state legislators that are our neighbors. Those are in some ways the minor leagues for what we're going to have represented at the national level. And if they think highly of you as a practitioner, of the places that you work, and of physical activity as a resource for people to be healthier Americans and more active and engaged, they'll carry that with them.
All right. So there's a number of questions, and I think we're going to start with a question it's a pretty long kind of response, but I'm going to try to shorten it up a little bit. And the question is, how is the health fitness industry addressing underqualified exercise professionals? And when we think about, and the new term that's been popping up that we've been kind of discussing on from advocacy sides is a qualified exercise professional, which is a combination of certification, accredited certification from NCCA or ISO 17024, and education and experience as part of being that national exercise referral framework, and balancing that against those who are underqualified. So these are ones who are taking certifications that may not be accredited, open book exams. So how do you balance that? I guess I'm going to ask that to Graham, of qualified exercise professionals in comparison to those who are underqualified, and how do you address that in kind of the kind of grander access, the access side? Do you have enough qualified professionals to deliver it? And then I'm going to ask that question about the community-based side for Lori. But I'll start with Graham first. We talked about qualifications.
And I think the best way to start on this is really when you look at our long-term aspirational goal, which was to have a secure place, with respect to the unique role of the exercise professional on the healthcare continuum as that provider of leadership and expertise and programs at a community level. And we've wanted that recognition for a long time, and we've had those conversations, and there have always been concerns about the quality of the education, training, and credentialing because it was all over the space. And this precedes Mike's time here, but it all started to move in what I would argue is the right direction with the Crunch versus Capati, where the high earner in New York died working with a personal trainer. And there was a $300 million judgment that was issued against those, and the industry was very concerned about regulatory intervention on behalf of the professionals. And so they looked at other adjacent health occupations that had high quality certification, where they had competency-based exams, they were accredited by reputable third parties. And many of the organizations in our space, including all of those that are associated with US reps, moved in that direction voluntarily. And we were making really good progress, probably right up until the pandemic, where we lost a significant portion of our workforce. I think when I looked in 2020, 21, and 22, Club Industry publishes a top 100 employers list, and I had an intern check all of the job descriptions, and they all required as a prerequisite that they had a current exercise professional certification from an accredited program. Well, we lost about 40% of the workforce during the pandemic globally. And so there was some legitimate concern on the part of employers was there an adequate workforce? So I think we've had some pretty significant backsliding in some ways on this to put people on the floor. But the bottom line is employers don't have to pay more for personal trainers or group exercise instructors that hold those quality credentials. So it's incumbent on the employers and the practitioners to earn and maintain those credentials. The analogy that I like to use is when you're a little kid and you say, I want to be an astronaut. There's a lot of things that means in terms of your education, training, your career paths. And kids will go, well, I don't want to do all that. I just want to be an astronaut. Well, if you want to be an exercise professional that's delivering services that are referred by physicians that are reimbursable, we have to do those things that that they expect from us. It's a reasonable expectation. And in today's regulatory environment, there's a big move towards deregulation. So we're not likely to see a push for licensure, but we can absolutely push for quality from within the space. And I think that that's a reasonable expectation.
So I guess to Lori,
Yes.
that question goes to you is when you're talking about scale and community-based programs versus treatment and kind of reimbursement for treatment, how does that work? Like whether it's step-down programs or et cetera, like you have to get enough people there. So how do you do it?
Yeah, I mean, so this is where we think about our work across the continuum. There are people who could easily go about and do their own physical activity if they were, if the clinician said, you know what, might be really great to think about more physical activity. They might be able to do it on their own, or they might be able to do it as part of an existing program in their community and pay for that. But then there are going to be folks that really need, and so that can be the personal trainer or, whoever might be delivering those programs in the community. If we're talking though about referring out to a professional from a physician, it has to be, the nutrition community has the registered dietitian, a licensed professional. It is really clear that that is who you refer to when you want nutrition services. As a physician, that's who I'm going to send my patients to. We need the same thing on the exercise side, or on the physical activity side, if we're going to want to position ourselves for reimbursement of services. So just saying, I'm not going to get caught up in the whole scope of practice conversations. I'm not going to get into that, but it will help our field if the organizations that do the certification can come together. If it's not licensing, I would suggest that it might have to be, though, if you want to be billing for services, that you at least have to have the professional that's clearly recognized as the person to deliver, who's qualified enough to deliver services and has the credibility from the clinician's perspective.
Thank you for that. So on kind of the final question here, and maybe I'm going to address this to Mike, and then we'll kind of go from there. Have other countries, because I know the HFA has an international side. Are there other countries that are further along in terms of exercise and reimbursement in an NHS model, and what can we learn from them?
I'm not sure if any are, outside of the United States is the most physically active community in the world outside of Sweden. And we're very proud of that. And I would say, that is likely the one to look to for strength. They do invest in preventive health care through physical activity. They do. And so I think the work that we're doing and the work that the Physical Activity Alliance is doing and that you all do out in your community will one day hopefully drive towards that systemic change here in the United States. And you can count on the four of us on the call and the organizations that we represent to continue to push towards that direction. In terms of who's doing it better, I'll be the nationalist all day to say that I love the commitment and the work that is done in this industry in the United States. And it's just about us harnessing it the right way, and enabling it to produce the results that we know it can.
Mike, I would agree. I think one area where there was perhaps some better leadership at one point in time, I believe it was Alfonso Jimenez did a very, very large study in the UK that was really around physical activity, and it was delivered through commercial health clubs and council recreation facilities. But that was one of the largest studies that looked at the impact of meeting the physical activity guidelines for individuals in those community-based settings, and they had terrific results. I want to say he published almost 30 papers off of that, if I recall correctly. But it was just that. It was a study. It didn't translate into anything actionable that was sustained beyond that. But I think, Lori and Francis, it goes to where you're talking about the need for that type of research. And then how do you get the traction under the wheels to make it sticky after that work is complete?
I think there are countries, I think there are countries that have integrated into the health system better than we have in the United States. Australia comes to mind. where they do pay their professionals in the exercise prescription, but they have a different health system than we do. And so we have a much more complicated health system and a much more expensive health system. So we have to find solutions that are unique to our system. But I think if you move out of the health system and into the community, there are just so many opportunities for us to build environments through advocacy, policy, organizational systems, programmatic change to make it easier for people, to just make it normative for people to do active living, walking to school, sports programs, programs offered in fitness centers and Ys across the country, making sure that our work environments are conducive to healthy physical activity, just where people spend their time, making it a normative part of the day. We can also turn our attention there too, so that it's not all on the health system or working within the health system. It's also just changing where we live.
And I thank you so much for your insights. And I'd like to thank Mike, Lori, and Graham for your tremendous insights on this. There's a lot more to come in 2025. There's a presentation at HFA that make sure you go. I know Graham's going to be on there. Mike is going to be there. Mike Stack's going to be on there, and I think a few others are going to be on that presentation. Get involved. Watch those presentations and ask a lot of those hard questions for folks. Thank you again for joining today's call. I sincerely appreciate our esteemed panelists. Thank you, everybody.
Thanks for having us.
Thank you. Bye.